Hello everyone, I'm Dr. Sandeep Madan, anatomy faculty. So I'm going to discuss some important questions from neuroanatomy, and these questions were asked in my Telegram group. And you can see the link to my Instagram, YouTube channel, and the Telegram group over here. So let us discuss these questions. This was the first question where some marker is there, and they are asking that which of the following will project efferent fibers through the marked structure. That what is the marked structure? So when we look at this part over here, this is nothing but corpus callosum. This is corpus callosum. Lower down, what is marked over here is the fornix, and what is present in between is the septum pellucidum. This is septum pellucidum, like this. And septum pellucidum is the septum between the two lateral ventricles. So we can say these are the two lateral ventricles, and these are the two thalami. Now T for thalamus, T for third ventricle. Between the two thalami, we have third ventricle over here. What you can see over here is the caudate nucleus, and this is looking like lens. So it is lentiform nucleus, which is further having two parts, globus pallidus and the putamen. And if you can see, these fibers are nothing but internal capsule fibers. And moreover, over here, this is what is called as insula, because this is cortex, this is also cortex, but this level of the cortex has gone deeper. This is called as insula. This will be called as insula. Now dear friends, we have understood all the markings over here. The labeling is clear to us, but what was the marking given to us? This fornix was given, and the question says who will be sending the fibers through this like who will send, like whose efferent is called as fornix? Very simple answer is hippocampus. And we have one mnemonic that says hippomace. What is hippomace? This is the mnemonic for Pepe circuit. Hippocampus will send the fibers to mammillary body via this fornix, okay. And then what will happen next? Mammillary body will send the fibers to anterior nucleus of the thalamus, then to cingulate gyrus, and then to entorhinal cortex, and finally to the hippocampus. This becomes Pepe circuit. This circuit is important for recent memory. Moving on to the next question. So what again we have got a marking. It is on the corpus callosum, but which part of the corpus callosum we can see? This anterior most part is the bend, which is called as genu. This is the body or the trunk. Behind the splenium, but what has been marked is the rostrum. Now anterior most part of the genu is related to anterior most part of the brain, that is frontal cortex. Below the frontal cortex, this particular portion, below the frontal cortex portion is behind the orbit. That's why it is called as orbital cortex. Try to understand, this part of the cortex is related to orbit. That's why the name is orbital cortex. Otherwise, it has nothing to do with the vision. Okay. The visual cortex is also called as striate cortex, which is present in the occipital lobe. So answer will be B. Next question. Internal arcuate fibers of the medulla comes from where? Answer is nucleus, gracilis and cuneatus. Let me explain. We have the dorsal column fibers which are entering in the spinal cord. Very few fibers will relay, mostly they will move up. So the fine fibers, when they enter the spinal cord, they prefer to move upward before crossing. Why? Because they want to cross at the level of the medulla. So when they reach, they will be crossing, okay, because they have got the nucleus gracilis and the nucleus cuneatus present in the medulla, and when they cross they make an arc. This is called as internal arcuate fibers, and they will further go up as medial lemniscus. So straightforward answer, internal arcuate fibers are nothing but the crossing fibers, okay, of the dorsal column tract, which will continue as medial lemniscus. Now some marking is given on this vein, and the question is, this marked vein drains into what? Let us look at this vein. And here you can see, if you can observe over here this part, I want you to focus here. This particular part is behind the mandible. So can I call this as retromandibular vein? Yes. It is dividing into anterior and posterior. Now this marker, posterior vein, is meeting with this vein which is coming behind the auricle or posterior to the auricle. If it is coming posterior to the auricle, we can say posterior auricular vein. So posterior auricular vein with the posterior division of the retromandibular vein is meeting and becoming this vein. This will be external jugular vein. And external jugular vein will be draining into subclavian vein. Do you appreciate this? So this is subclavian vein. Answer will be a subclavian vein. But I want to show you one more thing. Let me put all the labelings over here. You can see now this is the retromandibular vein, this is the parotid gland. Okay, it passes through it, and then it is the external jugular vein. I want to focus on this vein now, subclavian vein. Why? Because I want to see this vein also, that is internal jugular vein. Okay, let me change the color, that will be better. If you can see over here, this vein and this vein, they are coming together, right? So we have the subclavian vein which is coming from the arm. Arm is called as brachium. So this can be called as brachial vein or brachial element. The jugular vein is draining the head and neck area, which is cephalic part. So we have one brachial element, we have one cephalic element. When they merge, they make what? Brachiocephalic vein. I hope you appreciate this part, brachiocephalic vein formation. And answer to this question is pretty obvious. Now we have already traced the vein, so we know. Okay. Now, again, the markings are given, but the question says which one is wrong marking over here. What about A? Is it corpus callosum? That is true. What about B is the fornix? We have learned in the section that above will be corpus callosum, below will be fornix. In between here, if I put some septum, what septum it will be? Septum pellucidum, correct? But anyway, that has not been marked. What about C? Is it optic nerve? No. C is not optic nerve. That's why this is our answer. What about D? Is the cingulate gyrus? Yes. So others are true, but what is C is the third nerve, oculomotor. Where is the second nerve? Here. You can see this is the given marking. All the labelings are. Now the next question is this. One marker is given and they are asking what nerve has been marked. So answer is abducent nerve. How can we say? Because we can see this is the pons over here. So this will be midbrain and lower down it will be medulla. In the medulla, pyramids are there and this is the olive, and here we are looking at the third nerve. Where is the fourth? It will not be visible from front, so that will be behind. The thickest will be fifth. The marker is the sixth nerve over here. This will be seventh nerve, okay, and here we have eighth nerve. This will be ninth, this will be 10th, and this will be over here is the 11th nerve. And the rootlets between the pyramid and the olive, this is the 12th nerve. Let me show you this picture. Now you can see all the labelings what we have already marked, and we can also see from behind the fourth nerve is visible. And next question, internal capsule has what type of fiber? Is it having association fibers? No. Association fibers are those which will be connecting the two areas within the same hemisphere. Okay. So within the same hemisphere, we have the vernix area and the Broca's area, and the fiber which are connecting them are called as association fibers. Like one of the example, and these are the arcuate fasciculus. Commissural fibers are those which will be connecting the areas across the hemisphere. The biggest example is the corpus callosum, otherwise any commissure for that matter. And what about the projection fibers which are connecting the cortex with the subcortical area? So projection fibers will be the answer for internal capsule. Why? It is having majorly the ascending and descending tract which are connecting the cortex with the subcortical areas. Now moving on to the next question, molecular layer of the cerebellum consists of what? Molecular layer is having basket cell and stellate cell. Let us look at this anatomy. It's very important area. So this is the cortex, this is the white matter, and inside again we have the gray matter nuclei. Because they are deeply present, it is called as deep nuclei. And what are the name of the deep cerebellar nuclei? We have the mnemonic: doctors eat good food. What is that? Dentate, emboliform, globose, and fastigial. Okay, but what about the cortex? If you take a section over here, you will see the layers of the cortex, you will see the white matter, and within the white matter you will again see the gray matter nuclei. So this is how we'll see the layers. We have molecular layer, this is the molecular layer, this is the Purkinje layer, and this is the Grander layer. And this, like, How can we say this is the Purkinje layer? Because it is neither fitting in the granular side nor fitting in the molecular side, and granular layer is the where the black dots are there. This is easy way to identify. Okay. Now, dear friends, we can see this particular picture is a schematic way to understand what are these cells. As I told, these are the basket and stellate cell in the molecular layer, but Purkinje cells in the Purkinje layer. But look at this part carefully. Only the cell body is there. Dendrites are above and the axons are below. What about these? These fibers are coming from olivary nucleus and they can climb up to the Purkinje. So because they can climb, that's why called as climbing fiber. But there are other set of fibers also, which will be taking the help of these small cells. These small cells are granule cells. So granule cells are carrying forward the fibers, but those fibers are actually coming from this. This is called as mossy fiber. Now just imagine whatever may be the number of total afferent areas for the cerebellum, only one afferent area, olivary nucleus, will be sending the fibers via climbing. Rest all afferent areas, they will be sending the fibers collectively as a mass, that those are coming as mossy fibers, and they can't reach the highest levels. They will be reaching the granular layer, and via the granule cells, that means in an indirect manner, they will be meeting up with the Purkinje cells. But then they will be meeting like one is to many. Okay, because one mossy fiber will make anastomosis with many granule cells. Then further, one granule cell will make anastomosis with a lot of Purkinje cells. But climbing will be direct, but its impact will be 1-to-1 ratio. All right. So this is next question. What we can see, this is the corpus callosum splenium part. And what is the blood supply? This is at the junction of ACA and PCA. Let me show you this. Here you can see this is the ACA territory, this is the PCA territory, and this is the MCA territory. Look at the splenium at the junction. So it will be taking supply from both ACA as well as PCA. Now this is the floor of fourth ventricle. We can very easily see and identify, and we can see these are the dorsal part of midbrain, which is called as tectum, where we have four colliculi, two superior and two inferior. But the marker is on the pontine aspect of floor of fourth ventricle. And what is that marker? Facial colliculus. We all know facial colliculus is made by the seventh nerve, which winds around the sixth nerve nucleus. Correct? So the question says damage to the structure producing the marked elevation. Who is producing it? Seventh nerve. So if that is damaged, seventh nerve is gone, and that's why answer will be risorius. Why? Risorius is a muscle of facial expression. It does the grinning. That's one type of facial expression. Right? This is what you can see in the large picture. Now, next question is all are related to facial nerve except. Now, this is a pretty easy type of question. We know facial nerve exits via stylomastoid foramen, and then it will also supply posterior belly of digastric, because that is the one which takes, it is the derivative of the second arch. And facial nerve passes through the parotid gland, although it won't supply it, but it is definitely related to it. But maxillary process, no. That's why A is the answer. Next question, corticospinal fiber pass through which part of the internal capsule? Now they pass through posterior limb, but which part of posterior limb? Anterior two-third. Let me show you the diagram. We can see the genu and we can visualize here, suppose someone is present over here, his head and neck will be represented in the genu. So genu contains head and neck fiber, means corticonuclear fibers. But posterior limb, in the anterior two-third part, it is having what? Upper limb fibers, trunk fibers, and the lower limb fibers. All of them, they are present in what? In the sequence, corticospinal fibers. Also, it is having extrapyramidal fibers. Okay, so corticospinal fibers and also corticonuclear, but corticonuclear will be in the genu specifically. Okay, and the posterior part of the posterior limb is related to audiovisual fibers, which are passing specifically through the retrolentiform part. Retrolentiform part, this one, which is bringing the optic radiation, and sublentiform, which is coming, reaching the temporal area for the auditory radiation, right? Next question, efferent from the cerebellum. Now we have learned the afferent, that climbing fiber will send the fiber, then you see the mossy fiber will send the fiber. What about the efferent? So if I take you back to that particular diagram here, we can see Purkinje fiber will receive all the input, then they will process and they will take the output. So Purkinje cell is the output of the cortex, but what is the final output is the deep nuclei. Okay, because in the meanwhile deep nuclei has received the message from both climbing and mossy side also. or Purkinje side also. So if they ask from the cortex, their answer will be Purkinje, but they are asking from the cerebellum as a whole, answer will be deep nuclei. All is true about Brown sequence syndrome, except answer to this question will be ipsilateral loss of crude touch, because it will be contralateral. Those who know it, very well and good. Otherwise, let me explain. I'll start with the very basics. I'll give you a very basic idea. When the crude sensation come, this will cross. We can remember CC. Crude sensation will cross within the spinal cord. When the fine sensation come, they move upward. We have discussed also the dorsal column was moving upward. If you combine them together, this becomes like fine will cross and crude will cross. I hope you will remember now. And dear friends, based on this fact and based on what is LMN and UMN, we can easily learn about Brown sequence. Let me explain. What is LMN? Lower motor neuron, but that's the full form. What is the meaning? Any nerve will be LMN. And what is UMN? Any descending tract, corticospinal or corticonuclear. You can say pyramidal tract, right? This is a simple meaning of LMN and UMN. Now let us look at the pyramidal, let us look at the Brown sequence syndrome, which is also called as hemisection. So this is what is the spinal cord, the midline. We made the cut in the half of it. So it is hemisection. Now this pain and temperature type of fibers are coming. If the pain and temperature type of fibers are coming, these are crude sensation. So they will what? They will cross. They will cross and then they can move up. But opposite side, they will cross, but they want to move up. Can they move up? No. So where is the loss? Contralateral loss of pain and temperature. So we'll make the box. Now fine sensation. When they enter, what will happen? They cross or move up? We know they will move up. Can they move up on this side? No. But opposite side? Yes. So where is the loss? Ipsilateral. And if I put these nerves, these are the spinal cord and the nerves will be spinal nerves. But any nerve for that matter will be LMN. These are nerves, but technical name is LMN. And these are the tracts coming down. But tract is UMN and it is getting cut by this section, right? If the tract is getting cut, this is where is the loss below the palsy. So this will be ipsilateral spastic palsy. Why? Because UMN is gone. And where? Below the lesion. Now, when we are cutting the cord, at least where we are cutting, the nerve will be additionally damaged. You check this part. Only this nerve is getting damaged, right? So if this nerve is gone additionally, there will be definitely spastic palsy below the lesion, but at the lesion, there will be flaccid palsy. So these are the features of Brown-Sequard syndrome. Last question, not affected in the PCA infarction. Now we know basilar artery is present on the pons and just above the pons it divides, but it won't supply pons. So pons is the answer. Midbrain, all syndromes are because of this artery involvement only. Thalamus will be supplied, striate cortex will be supplied, pons will not be supplied. Thank you so much everyone. My best wishes. If you have any doubt, feel free to ask. Thank you so much. God bless you all.